Welcome to the Hard Things About Healthcare, where we get into the business and operations of healthcare that clinicians face every day, the challenges they present to delivering care and running clinics, and how they overcome them. The Hard Things About Healthcare is brought to you by Honey Health, the connected care platform for modern healthcare teams. I'm Matt Faustman, type 1 diabetic, and co-founder and CEO of Honey Health.
I'm Ginger Vieira. I've lived with type 1 diabetes for 25 years. I'm a diabetes author, speaker, and content specialist. Today's guest is Dr. Viral Shah. Dr. Shah is a renowned expert in endocrinology and diabetes technology. He serves as a board-certified adult endocrinologist and professor of medicine and as the director of the Diabetes Clinical Research at Indiana University's Center for Diabetes and Metabolic Diseases. Dr. Shah has led groundbreaking studies on advanced diabetes technologies like continuous glucose monitors, insulin pumps, and artificial pancreas systems, directly contributing to FDA approvals and reshaping the management of type 1 diabetes. Dr. Viral Shah, welcome to the show. Thank you so much for joining us.
Thank you for having me.
We're going to jump right in with the very first question that we love to ask every endocrinologist. Why diabetes? How did you end up here?
That's a great question and personal question to me. So being an Indian, if people are not aware, South Asian Indians are at a pretty high risk of developing type 2 diabetes. And so I do have a family members with both type 1 and type 2, and that led me into doing diabetes research. And lastly, I think 15 years or so, I have focused mostly in type 1 diabetes.
Okay. Well, thank you for, we need every endocrinologist we can get is in this community because they're few and far between, and there's so many of us who need your support. So thank you for dedicating your career to this.
Thank you.
So you have been involved in a variety of landmark studies that led to FDA approvals. Can you walk us through one of these projects and the impact it's had on type 1 diabetes management?
Yeah, I think I can proudly say that I was fortunately involved with many studies that I think a lot of people with type 1 diabetes are now using those technologies. So think about the Dexcom CGM. I was a part of their pivotal trial with the Dexcom G5 and Dexcom G6. Also, I think sometimes people may not remember this because this is a little bit of an history. We used to have a fingerstick confirmation requirement by the FDA when you use the CGM. So we did a study called Replace BG at the time. That study, the data from that study led the FDA to get rid of that fingerstick requirement. So in that study, it was a pretty simple two group of people, people who would do a fingerstick for a confirmation before they make the insulin decisions. Other group would not do that. And we just looked at that the outcome must be similar between two groups, and particularly the safety, because that was the concern by the FDA, that what if your CGM is not accurate, right? And we showed that, nope, it doesn't matter. And so I think that's one of the beautiful study that has been given less attention to, that I feel like was one of the best. And of course, I was with
Yes.
other insulin pumps and automated insulin delivery system, particularly Omnipod 5, Tandem Control IQ. And so, yeah, I can speak a volume on different devices. And
I have a question as a patient on that calibration feature. As a patient, I just assumed that they hadn't developed the technology well enough to not need a calibration. Was it that the FDA was requiring calibration entry, or is it kind of a mixed?
So again, I think the regulatory agencies have a good job to make sure that people are safe. And so I think their regulatory requirement made sense in the past. But we all know that it takes a time for a regulatory agency to catch up with these advances that are happening, right? So the previous requirement for both the calibration as well as the fingerstick confirmation for insulin dosing were coming from mainly that the CGMs were not accurate enough. They were good enough to really guide you to really help you to optimize your diabetes care. But now think about that. This was way before we had a first automated insulin delivery system that was a Medtronic
Hmm.
670 market, right? So there was no automation. Everything was done manually by patient, either using injections or pump, but still it's all 100% user's input. So I think those were kind of, in my opinion, justifiable thought by the regulatory agency at the time. But then later on, once particularly when we had, G4505 software that led to a G5, if you remember, and then G6, right? And then that's the time period. And then the but Libre came in, with the Libre 2 and 3. And we knew that that does not require any finger stick, neither calibration because it's a factory calibrated, nor finger stick replacement for insulin decision, because these
Mm,
CGMs are going to be used for automated insulin delivery system that doesn't ask you to do every 5 minutes finger stick to
right.
do that, right? So I think the things evolved, and the data that we provided to the replace BG, and I think the thanks to Roy Back, I think he led that large work, giving the data to the FDA and making sure that they are feeling comfortable that nope, it's really good enough to now put
Yeah.
that out. And now nobody thinks about it, right?
No,
Yeah.
right.
Uh,
Right. I actually know a very specific example of how that calibration requirement put my friend's life in danger because her CGM stopped giving her data. And she was so low that she had parked her car right at the edge of a cliff. I had just gotten out of the car. We were unloading to be at a diabetes camp for kids as adults. And she was her Medtronic CGM had stopped giving her data because it was requiring calibration. And this is, 10 years ago where it would just stop until you gave it a blood sugar reading. And we all couldn't find her for like a half an hour. We finally found her unconscious. Her foot was on the brake and she could hear us, but she could not move. And she was unconscious. Her toddler was in the back and
Mm.
had called daddy on the iPhone
yeah.
and said, "Mommy's not waking up."
Wow.
And so that wouldn't have happened if she had a CGM that didn't require calibration.
Yeah, you guys are living in this world 24 by 7, and you know this better than me that how risky it is to manage type 1 diabetes. And without these proper tools, it's tough. It's tough.
Yeah.
Yeah. Dr. Shah, do you think that that research has helped with the exponential growth of CGMs just over the last like several years? When we've really seen it explode, and it's really starting to make its way into our type 2 populations. Obviously, insurance coverage is going up there, which is probably attributed to some of this. We're starting to see it in just general health conversations and part of like just general wellness. So do you feel like that was helpful or a part of that explosion of CGMs and starting to move away from glucometers as a standard of care?
It was definitely one of the factors contributing to that. Don't want to say that that was the definite moment,
Sure.
but I would definitely say that getting away from the meter to use the CGM definitely helped the companies to really move in a faster pace. And of course, we know that the competition is always good for both consumers as well as the market. And I think having more CGM companies coming in, better CGMs, also having a more evidence, not just in type 1 diabetes, but the large group of people with type 2 diabetes. I think all this work over time has led to, now we call this as a glucose is a fifth vital sign, and
Mhm.
that momentum has now arrived that it's a vital sign, right? So let's say, for example, your Fitbit is trying to measure your heart rate, your steps. Heart rate is one of the vital sign, right? Apple Watch is measuring sometimes, or some other smartwatch, or like a blood pressure, oxygen. And
Yeah.
now the glucose has become that kind of like an essential substance for us to really think about having that in a day-to-day life. That I think, and that's where the proliferation of the over-the-counter CGM is also coming up.
Yeah.
Which, in my personal opinion, it's a good and bad as well, because I think I'm a scientific guy where I go by data, and I think that the way that we are moving, it's not bad actually. It's good, but it's so fast that the science is lagging behind further and further and further. So traditionally speaking, that I would like to have a science first before it comes in the market. Now it's the other way around, that it comes in the market
Yeah,
and then we try to catch up with the science later on, right? So, yeah.
yeah, yeah, yeah. On the note of CGMs, one of the areas that you've done a lot of work in is around this concept of the glycemic risk index, and that's something you actually talked about at the DTM. How did you start working on GRI? Like, what was the reason you started leaning into that? Was that because there was just so much data that was basically being thrown at endocrinologists? We were trying to find a single number to manage this. So, would love to kind of understand what got you moving in the direction of really evaluating GRI. And maybe actually, just for everyone that's listening that doesn't have the context, can you explain a little bit about what GRI actually is? And then we'd just love to know a little bit more about the history or your history with working with it.
Yeah. So, we did a couple of projects. So first I'm going to go a little bit back on how I got interested into CGM matrix. If you think about the first consensus around the CGM matrix that we call now time in range, time below range, it dates back to about 2011, where Hamsley Charitable funded a project. All these lead investigators and scientists came to a JEP center in Tampa and started like thinking about that. It was a 1.5 day of like a consensus conference, and it got iteration multiple times, and what we are using is not exactly what it was written in 2011, but it was just the beginning, right? And then with the increasing use of CGM in a clinical practice, so I moved to Indiana. Prior to that, I was working at the Barbara Davis Center for Diabetes in Colorado, which is one of the top type 1 diabetes center. And nearly, we published the data around that part. 80% plus people with type 1 diabetes at the center were using CGM. The goal that I started this program back in 2014 is that anyone walks into the clinic day one must get a CGM. So I can another say that proudly, that the work that we did. So we did this pilot projecting of initiating CGM from a day one. We followed these people for 7 years to see that what is the outcome look like of starting CGM from early in the course of type 1 diabetes. We published over 7 years that people who start the CGM from the beginning learns a lot about their diabetes management and do really well compared to people who starts later on in their life. Now it's a part of their ADS standard of care. So I think that's another moment. But then with more CGM, you have such a humongous amount of the data. And then the question starts in your mind is that what type of data is something that meaningful to have a conversations with your patient? That's number one, right? If I talk about like, let's say, for example, glycemic variability and some of the metrics, right? People will not be interested. The people with type 1 diabetes would need to know what's something that is actionable. So that's number one. Number two, from a science perspective, is that what kind of a data really matters? And when I say matters, meaning by that relationship with its complications, right? And so I think, anyway, in short, I got very much interested in about how you can use this data to convey the message to patients, to try to understand the science behind that part. And then still we are using this data more primitively, like we are trying to use the percentage of time in a normal range, higher or lower. These are like I call elementary math. The power of CGM is going to be more of an AI based prediction tool that we are now trying to develop over time. Now, all this time, I'm going to say that glycemia risk index part, this was a concept started by Dr. David Klonoff, who is the president of Diabetes Technology Society. So it was not my concept, it was his concept, but I got involved as a part of the committee in developing this. So What is Glycemia Risk Index? One way to think about it is that we all shop online through Amazon. We always try to look up around that which restaurant to go through Yelp or some different types of the online tool. And when you do that, what do you look at? So if I want to buy a new item, I just look at the Amazon and it says 5 star. Okay, that great, right? Now, 5 star doesn't tell you the more details about whether the product is good, whether it's a delivery is good, is it something cost effective or less expensive, right? But at least it tells you from the superficial level that it's great. Okay, I'm gonna jump into that part. Yelp restaurant, 5 star, great, but it doesn't tell you whether it's a food, whether it's a service, whether it's ambience, whether it's something else. So similarly, how can you tell that this is a 5 star sugar control, 4 star, 3 star? And that what is the glycemia risk index is. And what it takes is that what it takes two things into the account: the time that you are spending in hyperglycemia and hypoglycemia. So think about that. The normoglycemia itself is an exclusion of both hypo and hyper, right? And so if you take that and try to now come up with a mathematical modeling to say that this kind of a glycemia would be a 5 star glycemia, that would become an GRI. So it's a 1 to kind of, or 0 to 100 kind of a number. It can be plotted into X and Y axis. That's a hyper and hypo axis. But it's a visually like a one number that can tell you the quality of that glycemic control or glycemia.
And when you say can tell you the quality of that control, was it intended to originally be really leveraged by clinicians or by the patient or by both, right? Because in that example of being able to quickly browse through which restaurants are 5 star, that sounds like it could be really, really valuable for clinicians as they're just managing massive patient populations these days and trying to understand who they should focus more on. So curious when you thought about and you and the team thought about, well, who are we building this for, right? And we think about this when we build products every single day. In your mind, who is the short term and even the long term real user of GRI?
Yeah, it was for both patient as well as the provider, but it's a slightly more heavier on the provider and the research side. So why I say that? So the future, I feel like what we need to do is if I have a patient with type 1 diabetes asking me a question that tell me, doctor, which technology is the best for me? In that case, we need to have a tool, same thing like an Amazon, that can tell you that, okay, this is going to be 5 star, 4 star, 3 star, right? And those stars are given based on the ability of that technology to really give you an outcome, quality of life, and certain other parameters. So I think that is more about the patient side, where it's not, it's existing in a smaller stage or primitive level right now, but in the future I just feel like it would be beautiful to create that part where people can literally just try to survey by themselves and figure out what's the best. Everyone living with type 1 diabetes is different, period, right? We know this part very well. And if you say that this works for Ginger, does not necessarily mean that this is going to work for you. And so having that kind of an ability of like developing that part, I think would be good. And GRI can be a part of that matrix for those patient side, the outcomes where they can see that, oh, this technology can achieve that part. Provider side, I think it's a more the tool that I feel like it's more of a population based
Yeah.
tool and more of like an EMR. And I talked about that at the TTS meeting. The way I think is that the healthcare utilization is generally, it's called rule of 80-20, right? And this is true for many businesses, that 20% of the people consumes 80% of healthcare needs. I'm not saying that they shouldn't do it. It just this is unfortunate people that are socio-economically disadvantages, or lower health literacy or something else that they are actually utilizing the healthcare resources more often. But it's always utilized on a site that is an emergency room that could be an extremely expensive. What if we flip that part and say that in my clinic, that hey, if I focus on those 20%, can have a more follow-up, more frequent follow-up, try to develop an integrated care, it will save tons of money for in healthcare, right? So like for example, Mark Clements talked about at the DTS on a similar topic where in a gluco Antivirally Rise Alliance, the platform that he has developed, you can literally just say that, okay, these are, you can click and hover around and say that these are 100 people that probably has more time spent in a time below range or probably having extremely hyperglycemia. And these are the people, let's focus on that part, right?
Yeah.
People with a time in range of 80% with the time below of less than 2% probably does not need to be followed up every 2 months or 3 months. They know exactly what to do, and so let's not focus on them and the focus on those people that goes
Yep.
to the ER to get that insulin every time. So
Yep.
I think that's where the GRI can be a great population tool to identify those people. So that's where, and the research also, I think one of the side where GRI could be useful, because the GRI, it takes both hypo and hyper into the account. You require a smaller sample size to do a research and find out whether your tool is going to work or not. So let's say if you're a startup company and you want to do a small clinical trial just to find out whether I need to spend more money or just stop it here, you can
Yep.
use GRI to do that part, and do a small study, 1 month, 2 months, which will save your money and then give you direction that, yep, looks good, promising. Now I'm going to raise my $2 million and do a clinical trial versus, not sounding, good. Let's make some changes before we jump into the big thing.
Yeah. For what it's worth, we've started to use GRI inside of Honey Health as far as a signal to clinicians. So we'll push it into their EHR, so it's part of the pre-charting for every single patient, but then they can also see a continuum of the change in GRI per patient. And they have all expressed enthusiasm for this single number because it's easy for them to kind of see their entire patient population. And many of these independent clinics and larger health systems, they're quite literally seeing thousands of patients. And it's hard to find the folks that really need help in there. One of the other interesting things that we're starting to do now that we have the data, and it's related to your hospitalization question. Once you layer on the hospitalization data, you can actually start to create, at a minimum, correlations, and eventually you want to create causations of if someone exerts a certain GRI pattern or changes in their GRI over a certain period of time, the probability of them going to the hospital goes up by X, Y, Z. And if you can get ahead of that, at a bare minimum, it's saving a lot of costs, but you're also helping to keep a patient from reaching that event that would otherwise send them to the hospital. So that was a long way of saying I fully agree with your hypothesis of the power of this single number that takes into account a lot of different factors.
Right. And also, I think you mentioned about is not just the using that single number, but also using that kind of a prediction method, right?
Yep.
And I think that's what we need to now start doing it, is that sometimes I feel like the EMR or our electronic medical record houses so much of information. Yes, a lot of things that can be a junk, but I think there are a lot of different things that are really useful, but it just never being utilized and it becomes a part of the junk,
Yep.
right? Rather than that, utilizing that information to develop those kind of a prediction tool and doing something before it's coming
Yep.
would be, I think, ideal. I'm sure a lot of people are working on that, and that's going to be the future. We all are living in the world of AI now, right? So we'll see.
Yeah. Yeah. I think predictive AI is something a lot of people are working on. And I think everyone sees a future where this is happening in our lifetime, right? Or potentially in the next 10 years. We have that to where at least big events, right? It's getting out ahead of, whether it's making like precision changes. I think we have yet to see whether that will happen, but getting out in front of hospitalizations as an example, there's a lot of companies that are working on helping organizations and providers get in front of those, because there's just so many incentives to helping keep people out of the hospital or reaching those types of complications that send them to the hospital.
Right.
On a similar note, so from your experience, what are some of the biggest challenges in translating your research findings into clinical practice, and how can endocrinologists contribute to advancing this process?
That's a great question, and I always think about that, right? Like the way I think about it is that sometimes I feel like, oh, this is a great research I'm doing, but then how many people would really know what that great research is to them? Um, so dissemination of research, and I think you are doing that through podcast. I think that's one way. Is needed, and the dissemination has to be two-way. Number one is that the communication channels between the providers. um, we all kind of live sometimes in a silo of different universities, different institutions, rules, regulation. Everyone has their own expertise, right? And people who are like an, let's say, 100% clinical don't get enough time to read, to keep themselves up to date about like this, right? So how can we provide them an easy way to really summarize these researches that are going to be useful for them? And also, okay, I'm gonna go a little bit back here too, is that there are a lot of researches that suggest that it takes about 17 years for a physician to change the practice once the evidence is available. And the
Wow.
examples are that it took about more than actually 20 years for an aspirin to become a drug that can be prescribed by a primary care. Same thing for a statin. Think about that. CGM, how long the CGMs is CGMs are available in the market. Now it's almost close to 20 years, starting from a first, even though I do understand that the older generations were not good enough, but 20 years plus. How many people with type 1 diabetes in the United States are using CGM?
Right.
Less than 50%. And this is coming from the base center data through a T1D exchange. If you think really about the community practices and rural areas, then probably this number may be even lower. So the dissemination of research, if we can try to make it simple, easily accessible to the providers, we can reduce this gap. Okay, so that's number one. And number two is that one thing I really like about in type 1 diabetes is that ginger people like you, they are vocal. This is what I love about type 1 diabetes community, is that hashtag we are not waiting, right? And so if you empower people living with disease, then they will speak up. So dissemination of research to them, what does that
Yes.
mean to you? And sometimes I see that your videos about, okay, what is this inhaled insulin? If people are not aware about it, they never consider that as an option.
Yeah, and then they don't ask their doctor, and their
Exactly, right?
doctor doesn't consider it, and yeah.
And again, sometimes the doctors, let's think about that too. Okay, they primary care, a lot of endocrine practices have only 15 minutes, and this is not by their choice. The hospital gives them an RVU and targets and other things. It's so funny that I just received a bill for utilizing some healthcare service recently for myself, and it says that, I'm not gonna give a specific age, but I'm making this up as a $100 situation. It says $90 for healthcare facility fee and $10 for a professional physician fee. So so the doctors are struggling with their time, the quality that they need to provide to their patient. It's not like they don't know it, but they want to take a
Yeah.
path of least resistance. So if you don't ask it, you are happy, I'm happy. I do not dwell into like a 5 different questions, right?
Yeah.
But if you ask them, they will answer that. And so, what I think in this kind of an healthcare situation where you don't have enough time, let's empower the people, those who are living with disease, particularly in our cases, type 1 diabetes, and let them ask those questions to their providers, and that will
Well,
open the door.
Yeah.
inhaled insulin is a perfect example of if the clinicians haven't really absorbed any of the newer research. Inhaled insulin's been around for like almost 10 years, and yet so many endocrinologists, I hear from the patients, right? They say, I watched your video, I asked my doctor, they said, no, it's only for type 2, it doesn't work for type 1, right? They haven't gotten any of that. They haven't had time to absorb or even be open-minded to, that
And
it
that's where
can
I
work.
think there's kind of a channel where we can provide them the easy way of digesting the research.
Yeah.
Like inhaled study just got published in Diabetes Care,
Hmm.
and
Yeah.
how to translate that research to the patients that they are seeing is really needed, and it needed multiple time. Remember that part, that one time is not going to be enough, right? We need
Right.
this part.
Right.
When we teach our kids, you have to repeat this probably 20 times for the kids to remember that part.
Right.
So I think
Well, in commercials, for Diet Coke, like we have to see it 17 times and they're still showing it to us, even though they're already buying it. I wish we could think of that research in the same way with that marketing angle.
Do you think that one of the things that you circled back on a couple of times with disseminating information is, maybe like podcasts as a better way of doing that? Do you think it's the medium that needs to change in order to improve the dissemination of information, or are there other ways that either the researchers or the providers can change what we're doing to improve that dissemination of the information? And I guess kind of clean slate, if you could remake this world, what would you do, or what ideas would you have to help improve how research is disseminated out to providers?
yeah, that's a good question. And my personal opinion, one size is never going to fit all, right?
Sure,
Whether
sure.
it's a dissemination of research or using certain drugs or devices in taking care of certain disease or people with disease. Um, and so I think we need to think about all these providers, asking them what they really need, what kind of a medium they need, and then providing the solution depending on their need is the best way. That could include the podcast, that could include some kind of a video library that they can just go and watch whenever they have a time. I have a friend who actually lives in Houston and has a long commute between the hospital, and he loves podcasts, right? But then other way around, I have, including myself, only social media that I use is LinkedIn. So for me, it's like, oh, I don't do much about other social media. And so I think each person is different. Some people are really into textbooks versus some people are. So if you develop an AI based tool where, okay, one thing is that, so in a PubMed, they have a feature. So PubMed is an NIH, is NHLB
Hmm.
funded platform where all the researches are housed, which are under that, PubMed licensing. Um, and you can literally create your account and put some kind of a search terminologies and say that I want to see this kind of an article every week in this format, in this summary. And it will email you every week on a Monday. You decide whatever you want to do and say, hey, you are a type 1 diabetes researcher. Here are 5 papers published in that. And now you can just have a look. So customizing your tool. So podcast is definitely again written down or probably translated using an AI language, right? People don't want to hear, but they might want some kind of a summary of one paragraph. Okay, there you go. I'm gonna cater you in a different way. So anyway, I think the solution needs to be a multifaceted to meet the need of different type of people.
Yeah, yeah, I agree. There's some interesting ideas actually in there, and especially with AI, you can do so much of this now in an automated fashion, and not in a not too distant future, it may even be able to generate videos for you to digest the information. I think that's coming sooner than we think.
I've been using openevidence.org. Dr. Ponder told me about it actually. And you can type in a question like, Tell me about research on using CGMs within the first 6 months of diagnosis. And it will just write up like a 5 paragraph recap and show you exactly which studies it's referencing. It'll give you 4 or 5. And it's really helpful as someone who writes about research and is always looking for work to cite.
That's amazing. I forget, is that created by OpenAI or is just coincidence on the name?
I don't know. I don't know.
Okay, we can look that up.
Yeah. So, moving on, I would love to ask you, where do you see the next big innovations in automated insulin delivery systems or artificial pancreas technology? And how do you think it's going to impact the next generation of endocrinologists?
That's another great question, and so I think the first part of that answer is simple: is that I think all automated insulin delivery system needs to be completely automated. And I think that's where we are seeing a direction. There are challenges for that, sure, but researchers are working on overcoming those challenges and making it as a fully automated closed loop system. At the same time, a lot of people with type 1 diabetes and totally understand that they want to have the devices to become more small, more user friendly, more, something that they feel like doesn't need to be like a robotic feeling, you know what I mean? And so I think if you have a pump and sensor in the same device or same channel, I think that would be appreciated. So I think there are multiple ways that I see that the innovation will happen, but I think I'm a technology guy and I'm biased towards the technology, so I think that's the field that excites me more. The other part that I feel like with this, all the data that are coming from insulin pump, from a CGM, from the EMR, as I mentioned, I think I'm also excited about tools to really tell you who is going to develop complication, who is not. Is there any way we can try to catch things early, customize, individualized treatment modalities? I think those things are coming up too. But at the same time, I want to cautious, I want to give a caution to people that I think the healthcare space is so regulated and so tight that sometimes you feel like, okay, it's going to happen tomorrow, but people don't realize that, oh my gosh, that tomorrow is going to be actually 5 years from now. The hospital environment is even more complicated. Hospitals are not that easy to really collaborate with, and so in that kind of a complicated and regulated space, the innovation dampens or slows, right? So I think that's kind of a word of caution from that side. Second part of your question was challenges, or how the endocrinologists are going to view those, the innovations coming up. And I think I consider that as actually challenges, one of the challenges. And why I say that, I have done type 1 diabetes, and I do only actually, 90% of my work is type 1 and very little type 2 diabetes. So I have become kind of a diabetologist from endocrinologist. I don't see a general endocrine, but most endocrinologists would prefer to have, being a general endocrinologist. In that situation, they have to keep up with adrenals, they have to keep up with pituitary diseases, right? They have to keep up with thyroid eye disease, and they have to keep up with diabetes side. And that's where I said that it's becoming challenging, because you have now multiple devices, multiple different things. And it's hard to remember hard to keep up. A simple exercise mode is named by every system differently.
Yes,
It's a
that's so
simple concept, right?
frustrating.
And
Yeah.
so it's frustrating for someone to remind me, what is this activity? Oh, wait, this is exercise, this is activity, this is what, oh, active insulin time, insulin on board. What is that? So it just the different terminologies, different things for a same purpose also complicates things. And I think the industry needs to realize that I totally value innovation. Everybody wants to craft their brand differently,
Yes.
But at the same time, we need to try to think about commonalities, try to making sure that there is some kind of a standardization, right? Do we use like a different toothbrush? No, it was very interesting. You Google that. There is an ISO standard for your toothbrush.
Oh,
It cannot be this long. Okay, it has to be certain length. It has to be so. I think it hasn't come that much into the diabetes space, and I would appreciate that. Again, I encourage the innovation. Everybody needs to do something different. They want
yeah.
their
But
own.
they're forgetting that in
Yeah,
trying to be innovative and unique, they're making it more complicated for patients. And the primary goal should be how do we make this as easy as possible for patients?
exactly. And then providers too. Don't forget the
Yes,
providers part, because if they don't
they're
understand, they're not
teaching.
gonna
Yeah,
tell their patients.
yeah,
And I do across. I speak at a lot of different institutions, different forums, and the common question that comes up is that it's hard for people to really remember, oh, how Medtronic works, how Tandem works, how Omnipod works, how iLet works, what are the troubleshooting part. It just getting into,
and watch out. Now you've got Moby and Twist coming, right? So
yeah,
you have more and more joining the market that they have to learn.
which is good in one way. We need that.
Yes,
At the same
it's
time, is that
amazing.
I just like, yeah, can you make that simple so that the providers and the patients can understand it?
Yeah, the terminology
Yeah.
should be.
Yeah,
Did
you
you have
have
something
like
on the tip of your
20
tongue, Matt?
different
Sorry.
brands of
Nope.
cereals
Nope.
on a Walmart, but then at least it's easy for anyone to understand these 20 different types of cereals. But that's not the case with us in device space.
Yeah,
Like, yeah, just
yeah,
One of the things that it enables as more products come in is personalization, right? Theoretically, is that we can find something that potentially fits us a little bit better. But that, and to your point, comes with a great deal of challenges in order for providers to personalize the treatment, right? And I don't know if you can speak to, and I'd love to hear your thoughts on this. And for endocrinologists that are having to see not only type 1 and type 2 outside the devices, like personalization, because everyone's different, is so big. And nutrition to the medications that they're on, it kind of runs the gamut. So as an endocrinologist, how are you creating, how are you thinking about creating personalized plans for everybody? And you're seeing thousands of patients. Like how can we keep that managed? That just feels like a impossible task when you think about just the sheer numbers.
it is, and it's a challenge. If you think about the American Diabetes Association standard of care recommendation on what you need to do at the first visit and the follow-up visits for people with diabetes, it's a one-page long table. Okay, just have a look at the table, and when you go next time with your physician and just see that how many of those points are checked by the physician. It's impossible, right?
Yeah.
Because you have a 15 minutes and it says, oh, ask about the hypoglycemia, make sure glucagon, long acting insulin, backup devices, this, that, check for neuropathy, make sure you have a FIB-4 score for your fatty liver disease, make sure you have an annual lab. I'm just like, this list is so exhausting, and I totally understand from a science perspective, but it's in reality, it's becoming difficult and difficult. And so what I believe in is called an integrated diabetes care, where it's a team-based approach rather than an individual approach. So you can have a pharmacist, you can have a diabetes educator, and that's what I do here at Indiana. I have started this integrated diabetes clinic where, in a same appointment, you can see a diabetes educator. Now it's totally up to you whether you want to see or not. um, I can have a social worker, I can have pharmacist. Pharmacist can help really to make sure that your titration for GLP, if you have type 2 diabetes or even type 1 diabetes, I use the GLP all the time. The titration, because it requires that to be up titrated every 4 weeks. Now I cannot see that individual every 4 weeks, but my pharmacist can. There are so many troubleshooting issues about the skin care with the devices, right? My diabetes educator can really take care about that part, that I probably sometimes even don't know that there is some skincare product available on Amazon at like literally $5. So The way I think it's more about like an integrated approach, and one of the pillar of that integrated approach, which is a challenging part, and I haven't done that yet, is having a primary care, because primary care is the key, and they should be making sure that all the preventive cares are done, annual labs are done, physical examination is done, because a lot of things are going to be missed by endo outside the diabetes realm, and so unless we do that part, it's difficult just by a single specialist, whether it's a diabetes, whether it's some GI or liver or something else, to really do that.
Real quick, as a follow-up to your comment on primary care, is it more about making sure that the patient has a primary care doctor, or the coordination with primary care doctors as the essential piece there?
Both. So you have to have, in order to have that coordination, and I feel like the coordination is an important piece. So I
Yep.
have been successful in about coordination between me, my pharmacist, my diabetes educator, and we work as a tandem, in a team. And they will message me in EMR and say that, Dr. Shah, I see your patient, I up titrated GLP, or I did that part, I changed some of the settings in this pump, that part. We haven't done that much with the primary care. And I don't know that's a realistic, but at the same time, I think we need to have an open communication channel if we really want to make that kind of an individualized care for a chronic disease model. And I do recommend all my patients that they should have a primary care. And the reason is that I'm going to be very open to them, then say that I'm not up to date on a CDC guidance about your vaccines. Okay, I try my best, but that's, oh, you need to get a colonoscopy done because now you are 55 and above, or probably 60 and above. I'm sorry, but it's just hard for me. And so I would like you to just make sure you are seeing a primary care and not ignoring some of those preventative measures. Now you're a postmenopausal female. Hey, you need to get a DEXA scan done to make sure your bone density is fine, and that's where the primary can do a really good job about making, hey, you got the flu vaccine, did you get the pneumonia shot, hey, you got this one, um, and so I think each one of us has a really good role to play here, in
Yep.
making sure that our people are healthy.
In a case where a patient already has a primary care provider, where are some of the roadblocks, or some of the areas where you see as coordination challenges with primary care, whether they be obvious or maybe not obvious to a layperson looking at this?
Yeah, and I think the challenges are the multiple directions. And number one is that the time challenge by, in a primary care office, as I mentioned earlier, that they are challenged with the volume of patients to be done. Um, and the documentation in EMR is a humongous, right? Even though you're seeing patients for 10 minutes, but then it takes another 10 minutes to document everything. And I feel like how much is the really value, or a life in a patient's life has been added by all this like an unnecessary charting that we do. But that's a part and parcel, otherwise you won't get reimbursed for legalities around that, right? So
Yep. Yep.
you have that challenge. Then you have got a challenges between, uh, if you go back a little bit and if you think about Canadian system, some of the European system, it's centered around a primary care, where primary care, NHS England, right, like a primary care is in charge of making sure that your preventative care is done, and then directing you to that, hey, you have diabetes, I'm going to send you to the endocrinologist, and getting a report from endocrinologist every 3 months to make sure that you are seeing an endocrinologist, right? They are the in charge to send you to the cardiologist, make sure that you get your cardiology follow-up done. uh, that hasn't been done much in our US healthcare system. I don't want to say that it's a generalized things,
Yep.
but some institutions, some centers are really good, some probably needs to improve on, but it's like a fragmented system, if that makes sense. I think everyone is
Yep.
doing something in their silo, and the other side has probably either no interest, no time, or probably no communication. So yeah, how many times I see that probably the same type of a blood work is done by primary care, by endocrinologist, by cardiologist, by
Oh
nephrologist.
no. Oh.
Oh,
like
you're letting.
overlap.
Yeah, can you just look and just see? I just get that done like 3 months back. So these are like a small example, like where we get lost into this complexity of healthcare and EMRs and other walls. Yeah.
Yeah. Is some of that just the fact that there's a lack of interoperability here in the sense that, and maybe if it's all within Indiana, this is solved because it should all be in Cerner or Epic for you. Is it more just a matter of not being able to see everything that's coming from the primary care, or is that one big issue, whether it be in
It's
hospital or potentially
it's
they're
a
seeing the
huge
primary
issue.
care outside?
Yeah, it's a huge issue within even organization. It's a huge issue, right? It depends on how that information is being displayed on your side. So let's say, for example, for an Epic user, it may be in a care everywhere somewhere. Now you have to go into care everywhere, look at the document, right, rather than probably coming up as a summary on your side. So Cerner has its own another huge challenges. It's a much primitive compared to the Epic, where Epic is a much standard EMR. But yeah, I think it's a big. I wish that the systems are much easier to work with, much patient centric, where and a little bit smarter. And when I say that, we talked a lot about AI. You have a duplication of diagnosis. So like, for example, in Epic, if you get a refill from your pharmacy, the same diagnostic code or something will again duplicate in your Epic because they just picked up. Or if the primary care enters that, again, so now sometimes you see type 1 diabetes 5 times in a problem list, right?
Yeah.
Why can't system automatically detects that and just, but anyway, I think medication, same thing. If you have like an titration of GLP, levothyroxine, some other medication, now you see suddenly when patient comes back at 3 months is that, oh, 5 different doses of the same medication, and then you're like, I'm not sure which one that patient is using, so, and you try to clean up, you spend your time, and the next time it's the same thing. So
Yes, every time I go in, it's like, no, I told you guys last time those last 3 medications I haven't taken in years. Why are we still talking
it
about
just
this?
comes, yeah, it's just a hard, like no matter how much you clean, it just comes back. It just, yeah, it's just interesting to me, like, oh my gosh, we need to solve a lot of problems.
Oh.
Yeah.
Well, so speaking of efficiency, as a final question for you, as a leader in the adoption of CGMs and pumps and automated systems, what advice would you have for endocrinologists to help them incorporate these life-changing tools, right, into their practice, but also efficiently, because they do come with such an extra workload?
My two pieces of advice to my colleagues would be number one, and that's what I would do. So, what I am preaching, I'm practicing that part is number one, just listen to your patient, right? I do understand the science, and that's what 80% of my time, as I said, it's a research. But people don't follow the textbook. And so just listen, and validate, what they think is the
And
best.
real life doesn't follow the textbook with type
Exactly,
1.
right?
Yeah.
And people are real life. So
Yeah.
um, listen, that's my advice number one. And if somebody is saying that, hey, this is not working for me, yes, it's not working for me. Let's admit that part and see and ask them, like, okay, what are the solutions that you think would help? My learning, my a lot of research actually is are being ignited by people living with type 1 diabetes. They are the ones who ask that kind of a question that, Dr. Shah, this is working if I do this way, which is like completely off level, doesn't make a sense kind of things, but it works, right? And then you are like, wow, if that works for you, works for you. And so a lot of things we learn is listening to people. Number two is uh, spending some time in developing an efficiency in clinic. So uh, why I say that part, like, for example, I moved from Colorado to Indiana, and I spent my 2 months of initial time in making sure that I have all the protocol. I met with pretty much all the educators. I met with every single industry rep, MSL, making sure that I have a demos in my clinic, so that when I talk about, oh, pump X and pump Y, they need to see. If I want to buy a car, I want to go to the showroom and see that, right? How can I just say that Google it and just look at the image? I want to hold it in my hand. I want to look at the weight. I want to look at the size, screen. Um, so I made sure that I have a demos in my clinic. I made sure that every single industry is connected with me. So if my patient is getting a prescription or something, they need help. We know how complex this is, right? Once they get that, somebody needs to train them. How are we going to open up that communication channel to make sure that these people are trained? And once they are trained, I want to see them back in 2 weeks because I want to make sure that this is working from them. And every pump nowadays have about between 30 days to 90 days of written policy. So I want to take that advantage because if that something is not working out for them in the 30 days, I want them to return.
Yeah.
Okay. And if I lose that, if I tell them that I'm going to see you in next 3 months, that window is gone. And then now somebody's locked for 5 years, 4 years. I don't want to see that, right? So crafting that policy, crafting that kind of an efficiency takes a time upfront. But once it's done, I can tell you with the guarantee that if I write a prescription upon 99% of the time, the patient gets it within 2 weeks and it's scheduled with me in 2 weeks of their training, period. And if it's not with me, with my pharmacist, 99% guaranteed.
Right.
So, and this is all done without my involvement because every person in my team knows their role. We met frequently. We have, discussed this part. We have a common goal. So anyway, so spending some time upfront, and this is a tip for actually an early career who is starting their clinical practice soon. I think this is a critical tip that spend about a month or two, but that month would get you a long way in making sure that your people are happy, you are delivering the quality of care.
That's incredible.
That's
That
great.
really, because your brain as a primary researcher, right? You said you spend significantly more time doing research. You're so pragmatic and systematic, but I can hear that everything you're doing is wrapped around compassion for the patient and helping that patient survive and thrive. So I really appreciate the approach that you're taking and that mindset that you're putting into your entire practice. That's incredible. Thank you.
Thank you.